Domadan, this is what I've just learned. This is all the Serbian I know, so I would speak in English from now. First of all, I'm really grateful for this kind invitation. I'm also very grateful to be back again in Pančevo. This is my third time that I've come to this beautiful town. And I've always been given fantastic hospitality. So I'm really grateful to Mladen to invite me back again. Association also and society also need to be thanked for having me back again here. Now, I have a difficult task to talk to you. You know, can the model that we practice in England, can it work here in Serbia? Whenever I go and speak to different people in different countries, they almost have the similar stories. They would tell me it is very difficult to do what people in England are doing because they perhaps have more resources, they have more money, the government spend more money. But I think the stories are very similar. So we have a choice. I always say to my colleagues that we have a choice. Either we can come to these meetings and we have the same discussions, that it is very difficult to change, or we run with whatever resources we have and try to bring the change. Because unless we would like to bring the change from within, it will not come from outside. So hopefully, at the end of my lecture, I would show you two models, or perhaps three models. You would like the Serbian model, I can assure you. I'll show you what we did in Portsmouth for a few years when I trained people. Then I would show you the model that practiced in England, the English National Training Program. I'll show you what were the different steps of that program and what was the success of that program. And then hopefully give you some idea of perhaps what could be done here. So wherever I go, I'm asked where do I work and live, and I say I work in Portsmouth, and they say, is it in London? So I always say, no, it is a town which is about 100 miles from London. I think it is a bit like Pančevo and Belgrade. You know, Pančevo is trying to live very close to Belgrade and have its own name, I suspect. So now I have this map that I carry. So I show them where Portsmouth is, where the star is. There is no star in London. So if you come to Portsmouth, this is where I work. It's quite a nice town actually. It's on the sea. So if you come in summertime, which is about 20 days in England, you would see a very nice picture. It's a nice town. You know, people who've been there, they like it. Lots of rich people live there. I don't have any boat there. I just can take a picture. But you know, if you're interested in sailing, it's a nice town to be. This is one of the monuments. If you're interested in Navy, this is a very important ship that is in Portsmouth. This is HMS Victory. This is the ship used by Nelson to fight Napoleon in Waterloo War. It is still there. It doesn't fight anymore, but you can go and have a nice lunch, you know, in the afternoon on the ship. I always say that whenever you look toward future, or whenever you want to go toward future, you have to look toward your past, because the history of the past holds the key, in my view. So, whenever people ask me, you know, you have changed laparoscopy in Portsmouth, you brought such a big change. I always think, you know, I often used to think quite good about myself. But then I remember looking at this picture. This is a colleague of mine. He's a senior colleague. Somebody, there is a teacher sitting here in the audience, you know, who taught Mladen and lots of other surgeons in Pančevo. So they hold the key, in my view, to the future. This is Mike Thompson. This is a senior colleague. In 1981, this picture is taken in 1981. He was the first guy in England who brought flexible sigmoidoscopy in the clinic. That was a big thing really in 1981 to have a flexible sigmoidoscopy because people were doing rigid scopes. So he took this picture. You know, lots of people came. There is a director of the hospital, some nurses, some very important member from the mayor office, and they're all very happy because the flexible sigmoidoscopy has come to Portsmouth. So Mike Thompson told me that all of them had the pleasure of having the flexible sigmoidoscopy in his hand in the next 5 years. And I'm sure they were not smiling then, you know. It's a very painful procedure. So I look back when I want to sort of look further. This is what Portsmouth is. It's a large hospital. It's about 1,200 beds. We see about 320 cancers in our MDT. We operate on 250 every year. I'm a colorectal surgeon. Surgeons in Serbia are very talented. They can do esophagus, they can do rectum. I only can do colorectal surgery, so I specialize in colorectal surgery. This is just a personal story really, for people who are non-surgeon. This is the day I came for my interview in Portsmouth. You know, this is how hospital looked. They were trying to break it down, and my director was telling me, we'll build a new hospital. This is a good place, you should get a job here. So I have to believe in his words that this would be a good hospital. You know, this is all there was in 2006. So I did the interview and I got the job. This is what I had when I started laparoscopy. One stack, old Smith and Nephew stack. And there were 3 theatres which we used to fight for this stack in the morning. Emergency theatre, colorectal theatre and upper GI. So whoever will get to the stack first, they would do their case laparoscopically. And everybody else have to do open. So my registrar used to come 6:30 in the morning to get hold of the stack, so we can do a laparoscopic operation. This is England in 2006. This is not, like a underdeveloped third world country. This is 2006, which is about 8 years ago from now. This is one of my colleagues, Asha Snapati. She became the president of ACP. I was teaching her at the time. But things do change, you know, whether we like it or not. This is my hospital in 2011. They built a brand new hospital in a place where I came for the interview 5 years ago. Our theatres change. Remember one stack I showed you? No, we have 3 theatres like this in our hospital. And we also are doing robotics now. We have a robotic system in our hospital doing robotic surgery. Now, I'm not standing here saying it is all because of me. What I'm trying to show you is a journey that if you have aspiration to bring about change, change comes. Everybody wants to be part of success. Nobody wants to do the journey. But it's important to have a journey, and that's what I keep telling people. This is what we do. We run regional and national training program in Portsmouth. We train consultants from other hospitals. We take fellows. We have a culture around teaching and training, because I genuinely believe that when you teach someone, you become a better surgeon. Because to teach someone, you need to know all the good bits and all the bad bits. So that's what made me, in my view, better surgeon, by teaching others. We ran national training program. National training program is something that I would share with you in a short while. It was a 3-year program in England. And we also run training in different other countries very successfully, and this is a model in Portsmouth. Some of these centers, like in Moscow, Alexei Karuchan Center in St. Petersburg, that has become even better than us. You know, some of the centers become better than the mother unit because they can implement change. So it is possible. You know, it doesn't really matter how much resources you have. Of course you need resources, but you need determination and a mindset that you want to bring about change. So this is the real question. This is for the surgeons, so I do apologize, people who are not surgeons in the audience, but it is important to just give you an idea of why teaching is important, you know, why we should teach, what is in there for them. We published a paper from Somerset with Robin Kennedy to say that from 1994 to 2002, 90% of our elective cancers were attempted laparoscopically, and we published this in British Journal of Surgery. And people didn't believe it. People thought that we made the figures up. This is what happened in Portsmouth. You know, this is an older slide from 2011. I should get a new slide, but this is to give you an idea. 2005, end of 2005 was the time when I came, and laparoscopy became a constant standard practice. So it's not only me. I trained all my colleagues. I appointed new people who were our fellows, some of them better than me. So everybody started doing laparoscopic work, which means the total number of cases in the unit went up. So about 90% of our work was done laparoscopically. This is just a slightly older slide. We've done more than 2,000 cases. Just to give you an idea, of outcome. This is nearly 2,000 cases. This is elective colorectal practice, both cancer and benign. So about 3% conversion rate, mortality very low, length of stay is about 4 days. So what we changed in our hospital was a median length of stay of 11 to 15 days got changed to 4 days. So hospital indirectly made money. They did not buy new theatres for us, a new robot, because we were saying that we wanted. They wanted the results first. And if you save money, money goes somewhere else. But there is always money in the pot. I would like to stand here and take all the credit, if you say that I did it, but actually it's always teamwork. There are lots of people behind a successful scene. This is a very nice picture. If you see it from a distance at the back, it has a very nice rhythm. It looks very rhythmic picture. But if you just for a second concentrate on every person, what they are trying to do, effectively what every person is trying to do is to hang on to the pole. That's all they're interested in. How they look, they don't care. So they're interested in the process. They're not looking at the overall picture. Overall picture is what you are seeing. And that is so true in every success. You need a lot of people around you that would make you look good to bring the success. You need very successful and very motivated and very supportive colleagues as well. This is very important as well. This is not my colleagues. This is just a picture from internet to give you an idea. Now, why training is important? I borrowed this slide from Danilo Miskovic, who's actually a very proud Serbian, Swiss, Italian surgeon who works in England. And some of you who may have met him know him. He gave me this picture. This is a picture of one of the Serbian pilots in the First World War. They were going from here, from former Yugoslavia, going over to France to learn to fly in case they would come to war and they would participate in the war. So imagine what motivated this guy back in early 20th century to leave Serbia and to learn flying. He may not have an aircraft to fly, but he wanted to learn. So learning is in our blood. Learning is important. We want to learn, we want to improve. That is important as well. So, a bit about evidence. These are two papers that I picked where they looked at a number of things. First paper is from Les Bouquet unit in Sydney, I think, where they looked at a cancer outcome. They teach people, and the trainer did the same operation, and they compared the outcome. And the outcomes were exactly the same. The reason for that was that the technique was the same, whether this was done by the trainers or when they were taught by the trainers. So they looked at the outcome and they were the same. This is north of England, the North Tees Hospital, this paper was published. And they looked at anastomotic leak rate, operative modality and everything else, and they said you have a similar outcome provided you have a structured training program. This is a very important paper in urology world. These are urologists who first published breaking the operation down into simple steps and then teaching people each step before they could do the whole operation. This is a laparoscopic prostatectomies. This is a very important paper, and I was very interested in this paper when it was published. So you can teach people, so in each operation you can teach perhaps 2-3 people doing different steps of the operation, and the outcome do not change. This is a Japanese paper looking in pediatric surgery, similar outcome, really. So no matter which specialty you look at it, we know that training works and training is good. We know this intuitively, but we like to see evidence. So evidence is there to support this. This is a paper written by Danilo with myself, and we looked at effect of supervision. So people who were trained doing colorectal surgery with people who were mentored and the experts. We compared the outcome between the two, and you can see there's very little difference in either you are mentored or whether you learned it and become an expert, because the common denominator is the standardized technique. But there is a problem with this approach. When you are looking at result to know whether the technique is good or bad, in my view it is too late, because the cost is the cost of deaths. So instead of counting the cost of death or outcome, why don't we look at the processes that lead to this? So why don't we look at the training pathways of people who would learn in a certain way? Because if you could change pathways, hopefully you'll be able to change outcomes. That's a very Japanese way of thinking, but that is true. If you can change the journey, then the destination become irrelevant. The journey become interesting. How we can reduce the learning curve? This is just a photo for audience to find out. If I ask you, who do you think is expert in this picture? It depends who you ask. If you ask the bullfighter, he would tell you, I'm the expert because I made the bull stand on the head. But if you speak to the bull, he says, I'm just having a bad day today. I just missed him with a few centimeters, otherwise I would have nailed him. This is the problem with laparoscopy. It is on the television, it is in high definition. So your mistakes always are in high definition as well. So you need to be really good in what you do, and that is important to learn it properly. You might know this guy, I hope. Yeah, good. I was a bit nervous, I thought you might not know him. So I'm going to ask you what makes an expert. So forget surgery, for instance. Forget surgery or laparoscopic surgery, because I think most of you have no interest in that. But you probably have interest in this guy. How do you define expert? So I looked at internet. I thought, who should I pick as an expert? So he's, I think, expert in what he does. He's very interesting to me as somebody. I don't play tennis. One of my colleagues played tennis, and I'm hoping that he would arrange a match. Yannick Aladdin would arrange a match of him with him while he's here. But if you look at how he plays, whenever the match gets longer, it's very difficult to beat this guy. Because the longer the game goes, the harder it becomes for him to lose. And when somebody asks him, what do you think when you're playing the opponent? He has a very simple answer. He says, I just focus on hitting the ball one more time than the opponent, and I usually win. It's a very simple philosophy. So when he plays, everything looks very simple. Tennis is very easy, because he makes it look simple, because he's an expert. Not many of you would know him, but the surgeons might know him. This is Professor Bill Heel, who, in my mind, did the biggest achievement in rectal cancer surgery in the last century. He defined total mesorectal excision, he trained surgeons all around the world, and he reproduced his results in the hands of others. So he makes things look very easily when he operates. So that's the definition of expert in my view. So let me ask you a few questions as audience. Definition of expert, I think expert is somebody who have a very standardized way of doing things. So he does the same operation over and over and over again. Very boring way. If you ask patient whether you would want an exciting surgeon or you want a boring surgeon, most patients will choose boring surgeon, because boring surgeon will do it right all the time. Exciting surgeon might cut other things during the surgery. Expert is somebody who have a technique that they can reproduce and make it look very simple. And if it looks good, it usually works. That's what it usually works. This is the question for you. If I ask you, what do you think is this picture? Where this picture is taken? Any ideas? It could be Portsmouth actually on winter days. Portsmouth look a bit like dark and gloom. It's very difficult to know. Where is this picture? Mladen would tell me this is part of Pančevo, because he thinks Pančevo is the most beautiful place in the world. Maybe he's right. But if I say to you, this is Moscow perhaps? No? Very difficult really. But if I show you this and say, is this Moscow? You would recognize it, and you say, yes, it is Moscow. Why you recognize this picture? You recognize it because you have seen it so many times. And that is really true in teaching surgery. Interesting fact is, all three of these pictures that I have shown you are within 5 miles of Moscow. 5 miles of this radius. But we don't recognize the other two, we recognize this immediately. And that's what the trainees should look at. That's how surgery should be taught. You should give them the same pattern to look at over and over and over again, so then they can't miss it. When people become expert, they don't look at the best shot that they would learn. They do the basics first. They do it a number of times, thousands of times before the best shot comes in. So it is important really to remember. You remember the paper I showed you from urology? This is our paper for colorectal surgery, published in 2010, I think. Anil Jimenez published this with me. We look at modular approach, dividing the operation into steps, asking different trainees to do different steps, and we look at the outcome to see if it changed clinical outcome for patients. This is the idea. The idea is when you break operation in step, it's very easy to give them feedback, it's very easy to teach people one particular step and then move them to the next step. Feedback is very easy to give. And this is just an example of each module. Port placement, vascular pedicle dissection, flexion mobilization, joint and everything else. So there are different steps of operation really. Same module for left hemicolectomy. I'm just gonna see if it plays. If it doesn't play, it might come out of it. I'll just sort of shut this off. This is just an example of what I mean by steps and what I mean by standardization. This is some years ago, I think we presented this in Swiss meeting. I'll just fast forward it to you. Patient is like this. Yesterday we operated in Pančevo, and I asked my assistant, anesthetic colleague, to put the patient head down. She was very nervous. She was very good, but she was very nervous the patient might fall. It is very important to have the confidence of your anesthetist, otherwise it is very difficult to do this surgery. This is to give you an example of how, I'll just see if I can move this. Okay, so I would move this, so it would run. Patient is steep head down into the boots, tilt right side, so you can use gravity for your advantage. Then what we do is we put standardized port. I'm just going to sort of, these are the standardized port for TME surgery. 5 ports. Camera is at the umbilicus, 3 ports on patient's right side, one port on the patient's left side. So then you start off with medial to lateral approach. So you start under the artery, use monopolar diathermy hook. Artery is the blood vessel that supplies this part of the bowel. This is for non-surgeons. Surgeons know this very well. I always say that if you can name the artery, you should clip it, because it's good for your health, it's good for your lawyer to defend you afterwards. Then you develop medial to lateral plane in front of the kidney. I'm showing you this operation deliberately because this operation is done by 3 different people. But it would look similar regardless of whoever is doing it. 2 of them are my trainee and I did a bit of a proctectomy bit. I take the artery, mobilize everything else, dropping the pancreas, leave the swab at the top of the pancreas, divide the vein, and then this is a different trainee now, doing lateral to medial dissection in the flexure. So it is really like a paintbrush in your hand. It's like painting, if you know what I'm trying to say. Surgery should be like painting, because if you paint and if it looks good, it usually works. Then you have a swab put on the pancreas, you come in the lesser sac and you join both hands to release the flexure. So when I teach people, I'm holding the camera, that's why perhaps it is shaking too much, but the idea really is very simple, that when you teach somebody, they have to do these steps in a systematic way, exactly the same way. Now this is the start of the TME, which is the rectal cancer, so rectum is quite difficult usually area to go. I use monopolar diathermy hook to do the dissection. You can see for people who are non-surgeons, cancer is in this part of the bowel. You need to do hair in the holy plane, sticking around, trying to drop the layer by layer, really, dropping the nerves. It should be no drop of blood if you're in the right layer. It should look very, very neat and clean surgery. Then I'm just going to fast forward this because really the idea is to show you what standardization impact has. So progressing now anteriorly behind the seminal vesicle, prostate, counter traction is provided by assistant with a pledget, and you are just doing what I call a gentle touch technique. You move it all the way down, pelvic floor now, So you go below the cancer, you check that you are below the cancer, and then you divide the bowel. And this is all really standardized down to simple steps. This is dividing the bowel, which is sometimes a problem for surgeons, so we use anteroposterior cut, dividing it from front to back. It's easy. And you can see how low you are. You are right where the back passage muscles start. You are well below on the dentate line, or just above the dentate in this case. And you do 2 firing to divide it. So you put this stapler across, and you would see, you clamp it, you wash it distally, you check there is no tumor once again, and you do it in 2 firings. Why do it in 2 firings? Because you want, this is technical for surgeons, you want the 2 firings to meet halfway, so you can bring your spike very close to the central weak point, so you can take it out in the circular anastomosis. This is the 2nd firing. And that's how the staple line should look between the levator plates, anteroposterior cut. Then the spike comes from below, very close to the junction. As I said, you've taken the piece with the cancer outside, you join the bowel back together. You would see just a simple knock-on effect, no fancy instrument really. You know, people think it is very difficult to do without fancy instrument. Then you spike the gun together, you do the anastomosis, we do flexible sigmoidoscopy to check there are no bubbles. You know, it is like when I was a child, I used to check my bicycle for bubbles, you know, when it has a puncture. This is an interesting video. This is the video of Japanese culture. This is art of archery. If you go and learn archery from these guys, they would, for 2 months, I think, they would just ask you to hold the bow only. You know, they would not let you follow. Maladan did that. You know, when he was in Japan, he went to learn from them, and for 2 months they just asked him to hold the bow, and that was his training. You know, hold the bow, go home. Hold the bow, go home. Because they really have broken what they're doing into simple steps, and simple steps are important, you know. I'll move it forward. So simple steps are important because you concentrate on each step. The final result, when the bow hit the target, is very consistent, provided you hold the bow, you pull the arrow at a certain length, and you release it with certain force. So it's important really to change the pathway, not the end game. End game is very predictable. It's like going to factory, you know, a factory which makes a children toy. You say use the same material, same model, what would come out of it? It would be the same toy all the time. The surgery or elective cancer surgery should be a bit like this. It should be very predictable. I'm just going to fast forward this because you've seen this. This is somebody in Lisbon, different operation, same cancer, done in a different patient. I'll keep moving forward. Why I'm showing you this is that I can show you a number of these operations, but they hopefully should look boringly similar, almost same all the time. And that really is a success of a training program. If you can do it consistently the same way, you would have the same outcome. So this is somebody in Lisbon. I'm operating with Nunu, my colleague there. And you can see it should look exactly the same as you saw before in the previous op. So you get the idea, you get the idea what I'm trying to say. What about robot? People say, you have a robotic instrument now, you have robot as a new tool, that must be a very fantastic, it is a fantastic way to do it. It's like driving a very expensive car. But can you do the same operation laparoscopically or robotically? So this is something we presented, I think in Anatolia, we presented this in Turkish meeting. This is a direct comparison of robotic technique versus laparoscopic technique. So on one side we have a robot placement, other side is our standard laparoscopy. See if I can fast forward this again, just for the interest of time. See, robot is at the bottom, laparoscopy is at the top. Steps are exactly the same. Really, the whole operation is exactly, except the difference is, on robot side, I'm sitting on the console. I'm controlling everything myself. I don't have to rely on my cameraman. I don't get tired physically. I also have a camera that is very static. It doesn't shake because the robotic camera doesn't shake. But the steps of the operation are exactly the same. If you watch both pictures, they should look exactly the same. The anatomy should look exactly the same. because the clue for surgeon really is in anatomy, and that's the real important message that I want to sort of put across. So this is just to give you a flavor. I know I'm not talking all to surgical colleagues, but to give you an idea of what I meant. Laparoscopy on one side, robotic on the other side, nerves between the two, it would look very, very similar. So when I changed from laparoscopy to robotics about 3 years ago, I know exactly what I was looking for because I've done it hundreds or thousands of times the same way. And that's what I was trying to sort of put a message across. So this was the outcome of our paper, 227 cases, right and left dissections done by different trainees, no difference in clinical outcome or clinical convergence. This is important comparison. HST are our registrars or fellows in 1 year. We did 100 cases teaching them, 3% conversion rate, R0 resection of 99% almost, morbidity 1.5%, length of stay 4 days. These are NTP trainees. So NTP is National Training Program. People say you can't teach an old dog a new trick. That's what British people often say. This is NTP. NTP was senior surgeons, some of them a lot senior than me. They were being taught. We compared their data to our trainees who were young. See, very, very similar outcome for both half. The reason being is the constant technique and a common denominator of standardized operating. I looked at these trainees when they left my unit and they all became consultants. So I looked at their 1 year practice combined. This is their practice in their own hospital. 4 people, 335 cases, exactly the same outcome they had in Portsmouth. So which means it's not only they can do the nice operation when I am around or when they are in Portsmouth, they can go away from Portsmouth and do the same operation because this is really not any magical. Anybody can come and do it. So that was the conclusion from our paper at the time, that you could teach people in the same way, you can have more of the same. So perfect training program as a trainer should look something like this. You can reproduce another one of you somewhere. So he could do the same thing, perhaps better than you. I'm just going to show you a couple of slides for National Training Program and then show you the Serbian proposed model. This is a program in England that ran for 3 years. This was the idea, 150 surgeons to be trained, 13 training centers. These are the training centers across England that participated in the program. Portsmouth was one of the centers. And this was the idea. The idea was that established colorectal surgeons would go into the program, they would be supported by the hospital, they would go to some courses, which is cadaver course, animal course, case observation, and then they would be given what we call in-reach training. So they would come to my hospital, do a couple of cases, then I go to their hospital, teach them to do certain cases. And then we would look at the outcomes. Now this was important. We just didn't want to teach. We want to measure it. We want to objectively measure it, that how good or bad the trainee is. As a surgeon, we are very peculiar breed. We are very difficult people to work with. There is nobody better than me. The other person thinks there's nobody better than me. This is the nature of all the surgeons. So when you measure success, it's very easy to fail people and say, I don't think so, you're up for it, because it doesn't look good. You don't do it my way, so this is not the right way. So we came up with this objective assessment score sheet where you look at each step of the operation and you give scores. You don't tell me, does it look good or bad? You tell me how it scores on the sheet, because score will not lie. And also you could not just pass all your friends. That was another important thing in the program. This is just an example of the scores to give you an idea. 1 is done by the trainer and 6 is perfect. This is the data from the National Training Program. 1,500 cases. We learned that it takes up to 20 cases, 21 cases before the curve starts flattening out, which means people become competent. Remember the steps I showed you? This is the advantage. You can look at each score to find out which step the trainee is struggling. We all know that splenic flexure mobilization is difficult. It is true with the numbers even. After 25 cases, the curve is not plateaued out yet. But the setup and everything is very easy. You can also look at different trainees. And quite honestly, as a trainer, I am really, these two guys are okay. I'm not worried about them. I'm happy that they're going to learn very fast. This is the person that I'm interested in, that why the curve is not plateauing out. So it's important to recognize people if they're not progressing, and important to recognize them in time rather than tell them in 2 years that you cannot be a surgeon, because this is very important. So once they had done the cases, they were asked to submit the operation for assessment. Operations was looked using this chart to give them pass or fail score. And that's what it was. 20 to 40 cases, different patients. The important message out of all of this was that while people were learning it, they were not putting patients at harm. So people were not getting major complication while they were learning the surgery. This is some of the centers contributing, 1,500 odd cases, and some of the trainers who contributed within the program as well, to give you an idea that some of us work very hard as compared to others. And this was the impact on England nationally. You know what impact it had? In 2004-05, only 5% of our operations in England were done with laparoscopy for cancer. In 2011, the figures are around 40%. It has gone even more. So it has impact, overall impact. That's the cost saving. Now, you've seen all of this. I'll go past this. These are the total number of cases, cancer, polyps. This is the NTP data. You can look at the figures, leak rates, whatever. This is when people were being trained. What happened to 13 consultants, 408 cases once they finished training? Their outcome data, BMI is very similar. You can compare while they are in training and when they're doing it independently. Very, very similar, really. So no difference really when you look at it. So that was a conclusion of program, that it is standardized technique and a subjective assessment that make it a success. Now, that's all very good for England. Can it work in Serbia? That's a difficult question. So last night I was looking on Google. You know, I put in Google Serbian surgical model, or what is the model of training? Serbian model of surgery. So you know what happened when you put Serbian model of surgery in Google? This is what comes up, right? So I think you live in a very good country. You don't need to change anything, you know. This is okay. Jokes beside. So what is the major stakeholder in all this? What are the people this training program in Serbia would interest and affect? They are Department of Health, the government. I think our mayor was here. The government would be interested in this because this hopefully would save money for them long term. Patients would be interested. We must not forget, at the end of all this, it is patient that matters. If they have better outcome, they should be offered the better surgery. The surgical community would be interested in this, and then of course industry partners, you know, industry which support teaching event, training event, make instrument, they are interested in this. So they are the major stakeholders in my view, which need to come together to make the program a success. So how do you do that? I personally think the way it might work is to identify at least 3 centers in Serbia and make them into what you call hub or training centers. So you train 6 surgeons to begin with, up to the level where they become the trainer themselves. Because it's very difficult to run the program remotely from another country. You want in-house people to learn the technique, become really good at it, and you want them to train the districts. That's how it works. You know, it's an old-fashioned saying that you can go to someone and keep giving them the fish and they will not go hungry. But the day you will not go, they will be hungry. The best thing is to teach them how to catch a fish, and then you don't need to go there. They would never be hungry. So it's important to look at 3 centers, identify 6 people, up to 6 people, put them through the same training curriculum like in England, because it is an established curriculum, everybody knows it works. We have published it, there is evidence. And then train people to a level where they become regional centers. Then train surgeons from the districts. Then incorporate the training program in our fellowship. The societies would have to play a part in this. You know, they would hold the curriculum. The colleges, they have a stake in this. And I know that whenever I mention these things, people smile and they say, not possible here. We are very different than others. Actually, we are very similar, whether we like it or not. We may speak different language, but when we are happy, we laugh. When we are sad, we cry. We are very similar people across the world. And it applies to most countries. I think you must have a group of people come together, become what we call a minimal access focus group, who can be a coordinating group to begin with. It's important to do the politics right. You don't want to leave the politicians out of it. Important to include them, decision makers, because they have a huge impact. You can't just run this at your own. You will get tired. You need people to run with you. I also think that you must have a central data collection. That is important as well. So whatever you do, you must measure. How do I know that I'm any good? It's just because I keep telling you? It won't last very long, this approach. I must have data to back it. And that's important as well to do this. So my suggestion really for Serbia is that if you start off by identifying 3 centers, 6 to 8 people who train themselves to the level where they become the trainers, and then they teach the districts, that would be a good model to look at. That's the model that worked in Russia very well. That's the model that worked in Iran. They have 5 centers. Lots of people get trained now. Nobody needs to go and tell Iranian surgeons how to do it because they've learned it. And Serbian surgeons are equally talented. They would learn it as good as anybody else. So that's my proposal. So you will be pleased to know that I'm about to finish, right? So I think this is the most important slide for my talk. I think change is inevitable, whether we like it or not. We all resist change because with change comes the threat that I would become useless. That's why we want to resist change. We say, no. In old-fashioned way, it always works. This is something new. So either you can have an approach where you put your head in the sand and hope the change will pass you without affecting you. It will pass you, but when you take the head out of the sand, everything around you will be changed and you'll be left out. So the important thing is to become part of the change, so you can influence the change. That is important as well. And this last slide really is the message for young surgeons if they are sitting. I am very interested in young surgeons always, because I used to be young many years ago. Because I always tell them that this is perhaps the best time of your life. Live in the time where laparoscopy have come in, where the robotics have come in. This is where you would learn all this and you would practice all this. And you must not think that it will not affect you in your life. You will be affected. So you better become part of the change. And people see a lot of blockage and a lot of limitation. They say we have financial limitation, I have a young family, everything else. I always say, yes, of course they are. And you have to be realistic. But most limitations in our lives really are in our mind. That's what I think. Thank you very much.